Hi, everyone. Thanks so much for joining us. We'll begin in just a few minutes. In the meantime, please feel free to check your audio. If you do not dial in from your computer, you can use the dial-in number and the passcode that's displayed on the screen. Hi, everyone. Thanks so much for joining us. If you're just dialing in now, we'll begin in a few minutes. Feel free to check your audio. The dial-in number and the passcode is on the screen if you did not connect to audio over your computer. Good afternoon. My name is Aisha Azam, and I'm the Vice President of Medical Affairs at the Patient Access Network Foundation. Thanks so much for joining us on today's webinar. We're excited to talk to you about the importance of financial navigation and how to make a business case for this important tool, knowledge, and resource at your organization. A few housekeeping items before we get started. This webinar is being recorded. We will be sending a copy of the recording to all participants after the webinar. If you have questions during the presentation, we welcome them. Please don't be shy. Use the questions section on your screen to submit questions or comments to us directly during the webinar. We will allow for a question and answer session at the end, and if we don't have time to get to your question, we'll be sure to follow up with you directly. And stay in touch. We will be providing contact information for all speakers at the end of this presentation. Today, we're excited to talk about how to implement a financial navigation services at your organization. This is part one of a two-part series webinar. The second part will be this Thursday. Today, we're excited to dive into how to create a business case. I'm pleased today to be joined by two wonderful panelists, Angie Santiago and Dr. Naveen S. Angie is the manager for oncology financial advocacy with the Thomas Jefferson University Health System, Sidney Kimmel Cancer Center. She created and implemented the oncology patient assistance program that is utilized at the Thomas Jefferson University Health System. This program was initiated to assist patients with the acquisition of supplemental financial coverage over and beyond what is traditionally provided by the hospital's business office. Angie has worked in the healthcare environment for over 19 years within patient access, revenue cycle, and financial counseling. She has presented on financial toxicity and related topics at networking meetings. Currently, she is the chair for the Financial Advisory Committee with the Association Community Cancer Centers. Dr. Naveen S is a board-certified allergy immunology specialist. Dr. S treats both pediatric and adult patients, and his areas Of professional interest include nasal and eye allergies, asthma, sinusitis, cough, eczema, medication, and food allergies. In his daily practice, he is dedicated to teaching patients about their allergies so they are better prepared to stay healthy. He incorporates evidence-based medicine to provide the latest up-to-date techniques such as allergy immunotherapy, biologic therapy, and oral immunotherapy. Dr. Siga has treated thousands of patients and is committed to providing the best personalized allergy care to the community. Thank you so much for both of your time today.
Thank you for having me.
In today's webinar, we will first talk a little bit about PAN, who we are and what we do, and why we put on this webinar series. Then we'll dive right into the panel. We'd like to discuss with you define the value propositions of implementing a financial navigation series at your organization. We'll talk about the financials and explain the return on investment to both your patients and to your practice. We'll review assumptions and risks and explore strategies to get buy-in from your management team. And then we'll wrap up with how you can move forward from this webinar and identify post-implementation steps. We'll closely time at the end for questions and answers. The PAN Foundation is a national patient assistance organization that helps underinsured people with serious illnesses pay for their out-of-pocket treatment costs while advocating for more affordable care. Since 2004, we've been honored to help over 1 million patients with nearly $4 billion in financial assistance. This financial navigation series is something that PAN began last year. And hosting this webinar series, PAN aimed to provide resources to healthcare professionals and patient advocates as they implement and improve the financial navigation services offered at their facility. PAN is a safety net organization who's invested in the success of navigation programs across various healthcare settings. Our goal across the board is to support healthcare professionals with the knowledge needed to build the case for established and expanding their navigation programs. With that, let's go ahead and dive into the panel discussion. Angie and Naveen, so much of our conversation has been about how financial navigation operates at your organization today. I'd love to hear from you on not only how does your organization support financial navigation today, but what drew you into it? What motivated you to start this process and be able to really talk about the benefits of financial navigation to your team? Dr. Siga, would you like to begin?
Happy to do so. Thank you, everybody, for attending today. This is a topic that's near and dear to my heart because it's all about patient advocacy, and that's kind of how I got started. I wanted to be able to put the patient first. You know, we are here as clinicians to provide the best medical care possible, and with the changing landscape of medicine, that may involve products that are in the medical space that are expensive or costly, and you know the patient needs the drug, but you're fearful that there might be a cost burden that will not allow the patient to receive it. And that's kind of how we initiated this, education in my clinic, where I knew the patient needed a specific drug. I knew it was going to be expensive, and despite that fear of expense, I wanted to find out if there was a way where we could still allow the patient to get the proper care they needed. And that's how we started. It was kind of a trial by fire. We had knowledge about the product, but we didn't really know how to navigate the financial aspects of the process. And the process is quite lengthy. It's multiple steps that take place from enrollment, which is the initial application to apply for the drug authorization. And then from there, you have to do a prior authorization in most cases for most products, because the insurance wants to make sure that the product they're applying for has a correct indication. And then from there, approval. And then once the approval is done, you're not done yet, unfortunately. Now the next step is administration. reimbursement, which is of course the most important part of the discussion that we want to bring into the focus today, and then kind of understand that complete revenue cycle from enrollment to reimbursement. And then again, the final goal is to make sure the patient gets the right product in the first place. So we learned by reaching out initially to our pharmaceutical representatives, and thankfully we had some good feedback from their team, specifically what's known as the Field Reimbursement Manager, or FRM for short, if you've heard that term before. And through those pharmaceutical representatives and the team, we were able to start learning how to properly utilize the resources that the pharmaceutical industry has. And then they were also able to put us in touch with foundations like the PAN Foundation, where we could reach out to obtain further assistance if needed for the specific patient in need.
That's terrific. How do you find that your practice supports financial navigation today compared to how it may have supported it a couple years ago?
We were completely ignorant. So to be quite honest with you, we had no idea. I mean, I think most medical practices are unaware that these foundations even exist. Your foundation and others like it. It is surprising to most of us when we get into the medical field. To give you my example, I was practicing for 11 years before I knew about foundation money as a board certified allergist. So it's something that, it's not something that's being taught at the medical school level or residency level. Of course, that's not the focus of those programs. They're meant to teach you medical education. But I think that's one thing that is probably maybe needed to be taught to the providers is how to, navigate the financial system, because of course that is important. Billing codes and CPT codes and J codes and ICD-10 codes, all that stuff has to be properly understood. And I think unfortunately it's not being properly taught at the educational level, whether it's for an MD, DO, or nurse practitioner or PA. It's not really the focus of the education, which I think is lacking. And then from there, we got kind of stuck where we knew a drug was required, but then we would try to start kind of with the enrollment process and then realize that, okay, we got a rejection. We didn't know that there was a prior auth needed, or the prior auth got rejected or denied, or the patient's out of pocket was expensive. And that's usually the last hurdle that would stop the process. And once we heard that, okay, it's an expensive copay for the patient, or the coinsurance was quite high, that we would be then stuck and say, well, I guess we have to stick with the old inferior treatment plans because we don't know the next steps. And then this is where, through a well-informed pharmaceutical representative said, well, wait a minute, there are programs out here. We have programs, first of all, that we offer in our own system, which are financial support mechanisms to not only help patients get access, but also help providers get the drug they need for their patients, whether it's a sample program or a free drug program. And then from there, like I mentioned earlier, the field reimbursement managers really was the biggest connection that we made that kind of helped us learn how to be more knowledgeable about this process.
That's so helpful to know. Thank you. Angie, tell us your story. What got you into financial navigation, and how does your organization support financial navigation today?
Sure. So I started within oncology 10 years ago. When I applied to Jefferson Health, I applied to be a hospital financial counselor. I wasn't aware at the time until the interview that I was actually going to be stationed in oncology. I didn't know anything about oncology. I didn't know you can get cancer where you can get cancer. I sure didn't know how costly the drugs were. We sort of know chemotherapy is expensive, radiation therapy is expensive, but to actually know and see firsthand is a completely different story. One of the things, to go back to agree 100%, a lot of times when you're a hospital-based practice, I feel like the world is solved with three ways. As a hospital financial counselor, I was sort of trained more to rely on charity care. payment plans, and then of course applying for medical assistance. Unbeknownst to me, here's this whole world out here for manufacturer copay cards. There's this whole world for foundation assistance. And so as I identified sort of the changes within the practice that, I'm stationed here now, I need to look for more resources. And so that's basically what I did. I realized that there was much more out there to help our patients. And it's not just necessarily about their medical bills or even helping them get their oral medications. Financial navigation is also explaining to patients their insurance. There are so many patients that sort of look at it like, hey, I'm on the infusion schedule, so my insurance approves me. Why would I even get a bill? And not realizing what their cost sharing is with their insurance. And so, this role came to be in regards to just realizing there's so much out there. And I'm like, we could do this, we could do that. I started as one person. I'm happy to say that my organization supported us in regards to how we grew ourselves as a hospital-based system. We now are a team of 6 from 1. So 10 years ago, one person running around with a chicken with no head. That was me. But, it also restricted us. And, I know we'll get into that in a little bit, but, day one, I had to make a decision on which patients I reached out to because it was impossible to reach out to all of them. And so there was so much missed opportunity. And, current day, our organization, we reach out to every patient that's on our infusion schedule. We reach out to them, we explain their benefits, whether they're covered at 100%, whether they have Medicare in a secondary, or whether they're underinsured. And the reason is that it's really important, I think, within a financial navigator advocate role, that you introduce yourself to that patient, because today they could be covered at 100%. In 6 months, they might need to be looking at COBRA, and you don't want them to feel alone in making that decision. Also, you want them to know, wait, I have a support person. So you also don't want to run into your patient that is deciding between food shopping and picking up their oral medications, because we see that as well. And it's always amazes me how patients, same as me, day one, had no clue. So they're so like, oh my gosh, this money exists out there to help me, whether it's a manufacturer copay card or a foundation that's helping them pay their insurance premium or, something like that, a COBRA premium. So, our organization, I'm really happy to say that we were able to grow to be a bigger team. It took a while from a hospital standpoint. You have to show a lot on why they should expand their program. And sometimes, saying because I helped the patient at CVS, Rite Aid, Caremark, wherever the case may be, they're looking for the return on investment. So, one of the things that, that really helped was just that patient experience and letting them know that we follow that patient's journey.
That's terrific. And I love what you said about looking at the return on investment. And I think that, dovetails us perfectly into the next question. Looking at from an organizational level, why should an organization make an investment in financial navigation? What are your thoughts on this?
So I guess I'll start off with just that patient experience, patient journey. As mentioned, patients don't know their insurance, and they also don't know when there's, you want them to know, okay, I'm through my employer. I have 3 plans that I could choose from. Sometimes a financial navigator advocate could be that set of eyes to them that are saying, okay, this is the difference between these plans, because they don't realize it. I tell patients all the time, 20 years ago when I started working at Quest Diagnostics, you know what I picked my insurance off of? My emergency room copay and what my primary care doctor copay was. Everything else didn't make a difference to me. And so when you have patients that are actually in some type of treatment, you want to explain to them what those infusion benefits really mean to them, and if they need inpatient stays and whatnot. So I feel like, for me personally, the ROI to the hospital is great, but it's more the ROI to the patient. And so allowing a patient to understand the difference between a Medicare Advantage and a Medicare and a supplement, and, showing them, hey, you're better off this route, that education is priceless. And that's to me is, if I have a Medicare Advantage patient, it's great to be on some kind of foundation assistance, right? Because we know the out-of-pocket could be anywhere from $4,000 to about $8,000. I put you on a foundation, that's great. It's like a Band-Aid. I'm going to hope every year that foundation still is open for funding. However, if we talk about your insurance in regards to going maybe from a Medicare Advantage to a Medicare and Supplement, I've sort of now put something permanent in place for you. And so, explaining to patients that and educating them on insurance is, it's, like I said, it's priceless. It doesn't just help the patient, but also helps, like, I think, the hospital in the sense that there's not so much patient portion balances that have to get filled out, because now that coverage that they've switched to, or that coverage that was better for their needs, is being met. The other thing, of course, with patients, as mentioned on the slides, is that, we're helping address that cost burden. I know Dr. Naveen's going to say there's nothing worse than not letting a doctor be a doctor, meaning that if my doctor feels like this prescription is the prescription that I should have because he went to school for X amount of years and he's the subject matter expert, right? And then unfortunately the patient can't afford that medication, and now he has to switch medications, but we're not letting the doctor be the doctor in that sense, in my opinion. So, addressing those cost burdens for the patients and just being that resource to them. When we introduce ourselves, we always tell them that we're part of the non-clinical support team. I joke with most of my patients and say, I know I was always going to be the non-clinical, because when my kids were little and it was time to lose a tooth, they had to lose it at dad's house. Why? Because I couldn't be on the clinical side. But, addressing those cost burdens to the patient up front is a huge value to financial navigation as well, so that they're not leaving with the script from Dr. Naveen and saying, okay, I'm going to get it. And then they get to the pharmacy and say, oh, I'm not getting this. And of course, it increases your patient satisfaction. We sort of already addressed what's going to come, and we've made a plan on how we're going to help.
Well said.
Dr. Did you want to touch the practice side?
I agree. Great points that you've made there, Angie. It's, you've hit on the kind of the really important points are that, unfortunately, yes, the patients don't understand what their insurance coverage is, and we don't either until we look into it. As a physician, I'm going to prescribe a drug, and I'm relying on a team like Angie to help identify the processes or the costs, burdens that the patient's going to have to go through. And so it's, I like, as Angie said, to be the doctor and be able to prescribe whatever I think is appropriate medically. And it's not fun when you're hindered by that burden of either quote unquote not covered benefit or high premium cost for whatever therapy is required. Speaking as just kind of a general clinician, we know kind of just right off the bat that 70% of prescriptions that we provide to our patients are never filled. Now, there could be multiple reasons, but one thing that seems to never be addressed, and I'll get this feedback from some of my patients, nobody ever brings up cost. Nobody ever mentions cost, and I'll be the one saying, well, here's a copay assistance card, or here's use GoodRx for this process, or maybe you want to reach out to the manufacturer and see if you qualify for the free drug program because you're in a certain income level. And it'll be surprising, I'm not surprised anymore, but I'll hear this almost on a daily basis. I never knew these programs existed, and I never knew that these were options for me. And I've been a patient, these are Medicare patients, so these are patients that have been patients for years, and we're unaware of these processes. And it's kind of our goal today, to educate our colleagues here who are attending this webinar that, we have to take that responsibility, burden of educating our patients because it's not being, again, taught or it's not hard, it's not easy to find. I'm glad that we will be able to put this panel together because it's something that does allow for more education to be, provided to our team members out there that are in the same boat that I was when I first started, providing some of these expensive medications to my patients, and how Angie started, and when she realized that, yes, hospitals are kind of in a unique situation because they do have charity funds as their own independent kind of situation, but as a private practice, I don't have access to the hospital funds, and so we had to find a different way. And the bottom line is we have to do what's best for our patients. And one of the things I'll bring up, which is kind of on the bullet point here on the bottom for the practice, is that it allows for that continuity of care What we were sometimes having to do, because again, we didn't understand the processes, was that we'd have to send the patients out to a independent facility, whether it be an infusion center or a different medical clinic that was not under your control, where you no longer had control of the patient's care. And I never liked that. I just never wanted to lose. And the patients didn't either. Like, I don't want to lose you. You're the doctor I came to see. You're the doctor I want to follow. I don't want to go to another office or another clinic to get care. Why am I doing that? And partly it was because we didn't understand how to navigate the financial system to get the proper reimbursement, because we were worried about our bottom line being affected if we kept the patients in-house. And we did that for years until we finally learned that there is a way around that issue.
Yeah, a little bit of effort and education, though, has the potential to go a long way for patient outcomes. So that outlines the why organizations should make it an investment. How can they begin to do so? Dr. Siga?
So this is a great question, and because it's overhead is a big burden for any medical practice, whether it's a private practice or a hospital system. It doesn't matter. We are always worried about our overhead, and costs are always going up. We have supply chain issues now, so things are in scarce, quantity, including FTEs or employees. So it's hard to find qualified personnel. But going back to the point that we made earlier, which is if you want to be an advocate for your patients, there is a little bit of a commitment that you have to make at the beginning, where you need a dedicated team in place to help you with the navigation aspect. Most of the people that have staff currently are usually just kind of good for what they currently have, and they're not set up for this navigation aspect. They might have a biller that kind of understands how to properly submit claims and follow through on that process. But this is navigation for certain of these specialized drugs, whether it's oncologic drugs, biologic drugs, etc., require a little bit more education to understand how to navigate those processes. And unfortunately, it's a big learning curve, and you can stumble and fall quite hard if you don't have the proper tools in place. So, the first thing you have to assess, as it says here, to determine your organization's capabilities. If you do have staff members that have some understanding in this process or free time to help navigate this process, then we want to, take advantage of that situation. But most of the time, like I was hinting at, there probably isn't that person in place. So hiring a good biologic or financial navigation coordinator is a vital first step to ensuring that you can provide the care you need to provide. And yes, it is a burden off the bat. You got to now hire another FTE where you're paying out before you get paid back for that ROI. And it's a hard pill to swallow at first, but the benefits do outweigh the risks. And once you have that team in place, along with the assistance of the pharmaceutical industry, the foundation assistance, you can get up and running pretty quickly and see that ROI, very quickly.
That's a great point. And I think, that takes us back to something Angie said earlier. When you are determining your organization's capabilities or deciding if it's tools or technology you want to look at, you can't necessarily help everyone at once, right? So going back to what Angie said about identifying who are you really trying to support first, who are you targeting, and building out a process that can support that group, and then working to grow it further. But Angie, talk to us a little bit about some of the risks and assumptions in this place. What should people keep in mind as they continue on?
Let me add one thing, if you don't mind. Let me just say one thing, just so you say that kind of step-by-step approach, just to give you my journey. We started with the Medicare patients first. That was how we started with the process. We knew that with Medicare, they required the buy and bill process as part of the treatment plan for these patients, and we knew that that was the only way to keep the patients in house. So we had to learn and we stuck with just Medicare. We didn't do a commercial for almost 2 years because we wanted to make sure we were doing it right for the rules with Medicare. And then once we got comfortable with that, then we were able to move on to the commercial plans and now provide it to all others. And I'll let Angie kind of take over here for the risks, and then I can chime in as well as needed.
Okay. And so, as mentioned, I was sort of the same way, targeted anyone who was an out-of-pocket of $1,000 or more, definitely target anyone who's Medicare only, because they need a 20% unlimited. But I think one of the assumptions, of course, with having a financial advocacy navigation program is that it's an easy process. It is not an easy process. It's easy to use Google and find out, hey, there's a program for that manufacturer. And, in a couple slides, we'll give some key sites to really help, so Google doesn't have to be your best friend. But it's going to the patient. It's explaining their benefits. It's getting them to be comfortable to share their financials with you, right? Because that's huge too. And I've seen it a lot of times because, unfortunately, with cancer centers, sometimes when they don't have financial navigation, they rely heavily on their social workers, right? And the social workers are great. Something is better than nothing. However, if you are enrolling a patient into a copay card, right, and it's not an oral copay card, so it's for infusion related, or you are putting them into something foundation. What happens when you don't submit a claim to your foundation within 60, 90 days? It gets revoked, right? So it's not an easy process if you don't know who to network with. This is not just a role that you have to be familiar with your practice. You also have to be familiar with who's your AR or your revenue department, because as a patient, their explanation of benefits that might be truly an eligible claim to submit to PAN or submit to a manufacturer copay card isn't what PAN or the copay card is looking for. So there's definitely a lot of steps within this role. So it's not an easy process. As mentioned by Dr. Naveen, you should, good practice, best practice, you should know your field reimbursement managers. You should know how each one of your programs work, because at the end of the day, guess what? They are all different. My foundations, how I submit claims are different from one to the other. The basis is the same. My copay cards, the same thing. Who's going to post that? Where's the check going to go that, gets provided or cut from these foundations? So I think the assumption is that this is the easy path, and it's not. With the ACCC, the Association of Community Cancer Centers, we had the Ready, Set, Go playbook published last year in September. And page 2 or page 1, basically one of the first things we say is that it takes about a good 1 year to fully learn this role. It can feel overwhelming when you're not creating your own boundaries and what you can and can't do type of thing. So I think that's definitely a big assumption, is that, I have somebody there, and you don't realize from an administration standpoint how much that somebody has to do. Within my cancer center, this year, we expanded to also give cost calculations. So we give every patient a contractual cost estimate, so they know exactly what that 20% means to them. And that's not easy, because there's nothing in the system that just generates that. So it's a manual process that we have to do. So foundation of knowing the insurance, giving cost estimates, doing our homework for our patients to say, hey, this is what's out there, but it doesn't stop there. Once they're enrolled in something, making sure that that grant is actually being used for the patient. So I think that's definitely an assumption of how easy this role is. It is not an easy role, but at the end of the day, where's the value? The patient. The other assumption is that the clinic is going to lose money. I don't think that's true. Once, as Dr. Naveen said, once this program is running, you are going to see the cost savings to the role. Does that make sense? Okay. Sorry, I heard a little feedback there. And then, of course, the risk as listed, if you don't have the right training and the right guidance, you're going to lose out. And that would be the risk. I got $3 million awarded to my patients in January because everyone's out of pocket reset and no one billed. What did you really get for your patients? Dr. Naveen, if you wanted to add anything else.
Yeah, no, I think that, there's a couple points that, running a clinic is expensive. Or any kind of healthcare facility is expensive. We all know that. And then, like I kind of said, the initial investment of hiring a coordinator will be another expense. And then there's also one other concern that I always like to bring up too, which is sometimes unknown to a clinician, is the contracting with your payers. Sometimes those are not up to date for whatever reason. And this is where, again, your field reimbursement managers can help to make sure that you're going to get paid the proper amount of money that you are due before you initiate this process. And so it's, there's that whole, process of starting with understanding the enrollment process, the prior authorization process. But I think before you even get to that level, it is important to make sure that you understand from your payer perspective what your contracts are with your payers. Usually you want to be able to be ideally at 100% of Medicare with the commercial plans. Otherwise, unfortunately, there will be a possibility that the clinic could lose money. And some people don't realize that their contracts are at 85% or 90% or even 95%. And they never knew that because nobody reads those 60-page contracts. And then all of a sudden you're doing everything right and you're still not getting reimbursed. So you've got to do a little bit of homework there to make sure that whatever contract you have in place with your payers is reflecting what is currently appropriate for reimbursement purposes. And thankfully, I'm lucky enough to be part of an independent physician group, IPA, or independent physician association, which helps with credentialing part of my certain payers. But I know a lot of clinics don't have access to that, depending on where you are practicing in the country. But definitely reach out to your FRMs, because then they can help you figure that out before you initiate this process. And then if you do that correctly, then again, the loss of money issue is not as big of a risk. And then, I would concur that it's a one-year process of learning the coordination aspect of the education. There's a lot of moving parts, but don't. It sounds very daunting and like I shouldn't do it. The risk reward, is the risk is great, but the reward is also great, and not only for the patient satisfaction and getting them on the best therapy possible, but there'll be a benefit to your practice as well. From the financial side, there will be an upside to that as well, as long as these processes are done correctly.
That's very true. For the sake of time, I'll go ahead and just cover these materials. There's a ton of materials out there that are useful tools to get started. There's a handout saved in this GoToWebinar platform that attendees can download that has a list of these resources, as well as published journal articles about how to make a case for financial navigation within your practice or organization. At first glance, many of these organizations' tools may look like they're specific to cancer, but we have seen in our own day-to-day, as well as I've heard from Angie and Dr. Sika, that these resources really can be applicable to any field or any medical discipline. The concepts that they illustrate about healthcare insurance and how to optimize insurance, how to leverage patient assistance programs are wide-reaching. Definitely encourage you to check them out. So with that, Angie, how can organizations begin leveraging some of these resources in implementing a navigation program? What would you recommend they do?
So I think, first things first, you have to show whether it's a private practice or, a healthcare system, the value that this navigation program is bringing. And so for us, Excel was my best friend. Excel was my best friend to show the payments that were received through external resources, which allowed those patient balances to be closed. It also allowed us to show the dollar value saved from like the free drug compassionate use program for our patients. We think about some patients who lose their medical coverage, but it didn't just lose, it retroed, right? And they, now the patient had already been dispensed the infusion medication, and some of the manufacturer programs are very lenient. And so, that goes back to definitely making sure you are familiar with your field reimbursement managers. They are going to be the first ones that can tell you about copay programs, free drug programs, new indications. That was sort of how we got our foot to be able to expand to 6 FTEs, and also those patients and the outcomes, right? I got to the point where I personally felt like it shouldn't always be about the dollar value. So I started reporting out to my leadership my team's interactions with patients. So, on a monthly basis, we interacted over 1,000 times with our patients, almost to say, like, guess what, if we weren't here, who was going to get those referrals? Who was going to answer those 1,000 questions type of thing? So, that was a huge leverage to our navigation, financial advocacy program as well. The one-on-one training, I just had 2 new hires start April 25th, 2 different locations. And I definitely start with the foundation of any advocate role, regardless of what department, is you have to have a good understanding of insurance. How are you going to speak to a patient on what their medical coverage is when you're not confident in speaking on that? So we actually do our training to start off with insurance understanding, and then for us, because of our cancer center, cost estimates and how to actually, make them, but then doing your homework. When we reach out from our perspective to a patient, we need to be confident. We need to go to them and say, hey, these are your benefits. Here's what's out there. And so, that training with someone that's, experienced and been in this role is huge too. Or, using those resources on the prior slide to build that confidence. That's a huge thing as well.
Wonderful. Thank you for sharing that. So once we know, what the investment's about,
being organized is going to really help you a long way. The first bullet point on the previous slide was about having an Excel sheet, and I can't stress that enough. That is something that, if you're not familiar with Excel, it's probably one of the best programs to keep yourself organized, which is, in most institutions as part of your, it's available to you. And if you can't use Excel, you can use Google Sheets, which is free. And it's a helpful place to, store your thoughts and your processes so that there are no missed opportunities when you're starting this process.
That's a great point, Dr. Sigga. How would you recommend that someone begins the conversation with their team or with their leadership? As a physician, how would you even begin it with your colleagues or with your staff?
Yeah. So it kind of started for me, just to give you my journey, I started off with telling my boss I need to be able to provide these drugs and keep these patients in my office. I cannot let them go elsewhere because then I lose control of that patient's care. Patients don't like it. They don't want to go anywhere else. We as physicians feel that we are responsible for our patients and we need to be able to be 100% involved in their care, especially if we're initiating a therapy that we believe they need. And so that's kind of the thing that, you have to start off by saying you want to be an advocate for your patients. You're doing this because this is the best thing you can offer your patients. And if we don't have the proper team in place, we're going to lose these patients to a different center, and then we lose control. And then maybe we also lose referrals because now we're not getting that positive response from the patients to say, hey, this doctor can take care of everything for me, and he's introduced me to assistance programs that I was unaware of before that have helped save me money. It's kind of a win-win there because then you'll get the patient satisfaction, and then what's the best way to get referrals? Word of mouth. Once one patient's happy, they're going to tell their family members and their friends, and you're going to get more opportunities to help other patients. So the first bullet point there is exactly kind of this: is proper proper care requires continuity. Most medical diseases that we treat, there are chronic illnesses that will require ongoing management for years, if not for the rest of their life. And so we want to be able to provide that care. And then also the second point is provide the best care, which is that there are advances in medicine that we need to take advantage of. There are a lot of new developments every single day that are being studied and approved and helping our patients better than what we were able to do 5, 10, or even 15 years ago. My approach to how I take care of an allergy and asthma patient today has completely shifted from when I left training, 15 years ago. And so we want to be, kind of the cutting edge, as you highlighted in my bio. Evidence-based medicine is how I practice and how I approach patients, and that means that I want to provide the latest and greatest, therapeutic options for my patients.
Thank you for sharing that. Angie?
So from a financial counselor, coordinator, navigator, advocate, pick your word. I think the conversation personally for me started with knowing that I could be doing more. And so explaining to the care teams and my leadership in the organization, because my original position, I reported to the business office. So I was a business office employee stationed in the oncology practice. And so, just letting them know, I know we could be doing more, but I'm one person. And we could be doing more to help the patient. Once again, the patient satisfaction, I think, is what drives us all, right? Because we're here to help them during their journey. And so then also explaining what that means to the business office. It's not just about the RI. It's also about, once again, those insurance conversations and exploring other resources outside. To my organization, someone who was losing their insurance and needed COBRA, now it's like, wait, if you let me assess that patient, I might find a foundation to pay that COBRA premium for them. And now the patient can continue their care, which is, of course, the provider satisfaction. But for the hospital or even the clinic, you're going to continue to get paid through the insurance. So I think the conversation just starts with letting them know that we know we can do more, and then slowly growing it. I can't speak enough to making sure you stick to some kind of boundary on what you start off with. Until you're properly staffed, you will run yourself into a wall if you try to, do every single thing within advocacy. Our program is great and it's running, but trust me, I know there's still things that we personally can do to help. And so, when we get to those points, one of my next year goals, anyone who's Medicare A and B and doesn't have prescription, they are going to be on our list. Right now, they're not on our list, but we want to start addressing everything that could sort of impact a patient from a medical prescription coverage standpoint.
Yeah, the ROI, of course, is the biggest, I think, selling point to most HR teams, or HR personnel is, yes, you can be a provider and say continuity is important, evidence-based medicine is important. And then from the coordination standpoint, it's not an easy process. The staff that currently are in practice may not have the experience, the time, or the knowledge to navigate this process. So investing in that coordinator is vital and also will help your ROI in the long run.
Well said. At this time, we'll go ahead and transition over to questions and a question and answer session. Dr. Sika and Angie, thank you so much for that engaging discussion. I feel like there was so much out there when it comes to the entire realm of financial navigation that outlining the fundamentals and really helping people understand why really any kinds of financial navigation services should be introduced to a healthcare facility is so critical in the day we live in and how we operate today. If you have not already submitted a question and you do have one, feel free to submit it in the questions box on the right-hand side of your screen. You can type them in and we'll try to address them during this presentation. If we do not get to your question, we will certainly respond to you after the webinar and follow up. One of the first questions that came in, and Dr. Sika, maybe you can start and Angie chime in, please. What barriers did you experience, with your team when you began setting up your navigation program?
Great question. So, it was really, there's quite a few things. I mean, we kind of highlighted a lot of the points that were, mentioned earlier, which was that you have to have a dedicated staff member that is willing to commit the time it takes. We were first naive in how much time it did take. to do the entire process for just one patient, and from enrollment processes and then waiting for the authorization to come back from the insurance that the enrollment has been accepted, and then from there, understanding that there is a next step of what's known as a prior authorization. How do we do the prior authorization? What are the steps involved there? So the barriers were really just learning the process and having a dedicated staff member to commit to that. Thankfully, once we agreed upon, that we need to stop losing patients to outside facilities, we said, okay, we have a lot of Medicare patients that require this service, and we're going to task one staff member to learn the process. And so once we agreed to do that, because we were tired of losing patients to the outside facilities, then we were able to take that next step. So it is, again, hiring that one dedicated staff member initially, depending on the size of your clinic, of course, that is willing to put their full effort into this process. It's that person that's vital to help initiate the process, and then that person needs to understand how to communicate knowledge of the provider, the medical team, but more importantly to the pharmaceutical companies and the field reimbursement managers, because they're going to be the ones that have the expertise to guide you correctly from the beginning, and so that those mistakes are not made.
I think for us, for me, I can say one of my initial barriers was this role was created. We had about 50 physicians in this one location. So it was almost more for me, hi, I'm here, in regards to letting the care team know and building that relationship with the care team. Here I was trying to sneak into the office appointment before the doctor was in the room to go over the benefits and whatnot. Chasing the doctor, can you please sign this? And they're like, who is she? I need your signature for this free drug app. I need your signature for this copay card. So, we are part of the team in a sense, right? And so sometimes these roles aren't on site, and sometimes you cover multiple sites. So for us, one of my main barriers are just networking, right? In a sense of between the care team, between the business offices. When we first went live, we weren't on the Epic EMR system. So I was hounding the physician side for the business office. Can I please have that claim in EOB so I can build this copay program? So I think, one of the barriers is that once you have this role approved, is just making sure the right people are connected, and knowing who your go-tos are in a sense, so that you can, run a smooth program in a sense.
And going back to the clinician side for one more little point is that to make sure proper documentation is vital for approval. There is a specific set of data points that you need to mention in your clinic note when you're starting a therapy or continuing a therapy that must be documented. Otherwise, it'll be a difficult process for the approval. And that was another kind of barrier that we didn't understand at first. We always think, the diagnosis is there. What else do they need? My prescription and the diagnosis, end of story. But no, it's not that simple, unfortunately. There are a few kind of parameters that have to be documented and met for the insurance to agree to authorize that drug.
How did you document the patient's interaction in that way in order to support the case of financial navigation and to leverage your return on investment?
So, after we did the initial benefits investigation, of course, before we did we started the enrollment process, of course, I have to document the severity of the medical condition so that we know that they meet the clinical criteria for the drug. That's the most important first step from the clinical side. And then when you initiate the enrollment with your coordinator, then the benefits investigation starts. And then from that point is when we get the feedback of what the patient's responsibility is going to be. And then we have to have that discussion, as Angie mentioned. Okay, we realize that, okay, this person has a copay or has a co-insurance that they must meet. We need to have a sit down with this patient and explain to them what their benefits have, returned. And that really kind of goes away from me as a clinician. I don't really participate in that discussion. I kind of let my team handle that. But it's good to be aware of it so that you know that, if say 3 or 4 weeks go by and your patient has not received an approval for the drug, what's going on there? And usually it's because there has been either a lack of communication, either a poor response from the patient side, answering phone calls from either the benefits investigator or the coordinator to help navigate these questions so the patient's aware of the situation. And so, don't assume that once you sign the enrollment that things are hunky-dory. There is a lot of work that needs to still be done after you've done your clinical documentation and enrollment process that is happening on the back end to make sure that the patient does get approved. And it might come back to you that if the denials have occurred because of improper documentation or the insurance just denies it for whatever reason they have, and then you have to do with an appeal. So you get back involved again, and that's another hurdle that you have to learn to accept. It's part of the process, and don't be upset about that or frustrated by that process. I write appeal letters almost every day of the week, and usually that's the end of it. In most cases, we finally get an approval at that point, but in rare circumstances, that's not even enough, and you've got to do a peer-to-peer. And I do about 2 or 3 peer-to-peers a month as well because of some issue that just wasn't properly assessed or understood on the insurance end. So there's a lot of steps that the clinician has to be part of as well, and they can't be frustrated by that process. I now have a dedicated time in my daily schedule where I have to work on appeals and peer-to-peers because I needed to carve that out. Otherwise, there would be a delay in getting patients drug. So from the clinician perspective, eventually when you get to that kind of level of providing all this care, you're going to have to learn to make room in your schedule for these processes because it is going to happen.
Well said. There was so much involved in everything related to financial navigation, right? Whether it's about starting something brand new or whether it's just even maintaining your existing infrastructure and structure and keeping those interactions with patients. What if it starts to feel static? What if it starts to feel as if you're not able to make headway with leadership in making a business case, really expressing the need for increased wages, increased resources, increased technology or tools? What should you do? What would you recommend to our attendees?
That's a good question.
So for us, I think so from a non-clinical standpoint, you find your champion, right? You find your doctor who's going to voice for you. That's what we did at our one location. We didn't have any type of financial advocacy there, but this doctor covered 2 locations. So he knew what our main location was able to do with financial advocacy. And then when he'd go to the other location, it was nothing there. So it's almost like you're championing your main person, to say, I need you to speak for what the program brings. And, having a physician sort of go to bat can be helpful from a hospital standpoint. I don't know in your private clinic what happens, but I do know that we were able to have them see the value in financial advocacy to say, okay, fine, we'll put a 0.5 FTE. And at that point, I'd work with anything. So 0.5 or full FTE, something, because you can always, once again, build the program to say, if I had a full FTE, I could be doing X, Y, and Z.
Yeah, I think that the coordinator, who hopefully will understand the reimbursement side of things, will be able to be the fuel that helps convince the HR department that there is need for more assistance. You have to be on top of things. The stagnation, usually approvals that are not being approved is because somebody didn't do something, whether it was the coordinator, the physician, or the patient. So the coordinator has to be dedicated to continue to have a follow-up mechanism in place. Going back to that Excel sheet, documenting when you made your first, enrollment submission, and then, did you get response from the, yes or no? And, again, this is learning the steps really helps first, so you have those in place, and then making sure that you have a timeline in place to follow through on everything. And if there is a delay, something is wrong, and you need to figure out what that is. Was it a denial for a clinical documentation issue? Was it a denial because the patient never answer their phone because the insurance needs their verbal authorization before they can proceed with benefits. You have to make sure that all of those, and so what we do kind of preemptively after we learn from these mistakes of delays in approval is we have a patient sign a kind of a mini contract that they're going to understand that they're going to be bombarded with phone calls initially by these assistance programs, the insurance company, and the copay assistance program. So you have to be willing to answer the phone from these unrecognizable numbers because it will help speed up the process of approval. And so we give them that heads up. Educating the patient is important because they have to understand that they're part of this. They're part of the approval process, and they have to be aware of that so they can help get the drug approved.
So true, and it's also something that's coming on.
Yeah, the coordinator part of it, which Angie mentioned, is like that person is probably the biggest, with the physician too, to back him up or back him or her up. But you have to say, hey, if the coordinator says I need help, they're probably, more than right. It's a lot of work, and I've seen my coordinator come early and stay late after even longer than the clinician in some cases, because there's just so much work to be done to make sure the authorizations are completed. And when we saw that, I recognized that he was working, more than 40 hours a week in my practice, and I said, okay, let me tell my boss we need somebody else to join him because this is too much. And so, and at that point we'd already seen the ROI, so we knew there was a benefit there. And then once you see that initial ROI, you're gonna be like, well, there's a benefit to this. Okay, let's keep it going. Let's keep it going. I don't think it's gonna be a hurdle once you get that initial cycle of reimbursement coming in.
That's terrific. I mean, those an endless amount of ideas and opportunities, but they do take time. And you said it completely well. There was so much that can be done. This was a fantastic dialogue. Thank you so much, both Angie and Dr. Sikka, for your time and your enthusiasm and your dedication to these causes and to ensuring that these matters take the utmost precedent within your organizations. We're not done yet with our dialogue and with our conversation. On Thursday, we will be featuring part 2 of this webinar, Lessons Learned. It will be on Thursday, May 19th at 1 p.m. If you're on this webinar, you've already been signed up for it and you should be receiving the calendar hold. If you haven't already, you will get a reminder of it in your email tomorrow. What we will be featuring on Thursday's webinar is 3 additional experts who will be talking about the lessons that they've learned in depth. So what are the tactical ways that they've overcome some of the barriers that they've faced? Additionally, we will be seeing demos from 2 technology companies who have financial navigation softwares. The experts who will be joining us on Thursday to speak about their organizations and their processes come from a couple of different backgrounds. Some of them do not use any paid-for services and are really looking at relying on Excel, they're relying on free technology and foundation tools to be able to do their work, and others are using financial navigation software. So we're excited to hear the difference in those approaches and their perspectives. Our contact information is on the screen. Thank you so much for joining us today. We greatly appreciate your support. Thank you so much to Dr. Sikka and to Angie for your wonderful guidance and advice. We look forward to talking to you again soon.